Hello people, in this video we want to look at the pseudocyst of pancreas. So it is not a true cyst, right? Pseudocyst it is. Why you are calling it as pseudocyst? Because it has no epithelial lining. So it is a pseudocyst. Cyst is something which is filled with fluid, right? So this is a pseudocyst, and they have written of pancreas. Remember, it is not in the pancreas. It is a pseudocyst of the pancreas. Basically, where is it then? If it is not in the pancreas, it is in the lesser sac. Okay, so this is what is pseudocyst of pancreas. Then why is it called as pseudocyst of pancreas if it is not in the pancreas and if it is in the lesser sac? Because it is due to pancreatic pathology. It is because of pancreatic pathology, because of some problem with the pancreas. So what is it containing? It is cyst, means what? It is having some fluid. Then which fluid does it have? It has amylase rich fluid. Who makes amylase? Amylase is made by pancreas. So here you can see this is the pancreas in yellow, and above it you have a pseudocyst which they have shown here. So this pseudocyst contains what? It is containing amylase rich fluid. What does it contain? It contains amylase rich fluid. So this is a pseudocyst because it does not have an epithelial lining. Then what is it lined from? It is lined by fibrous granulation tissue. What is it lined by? It is lined by fibrous granulation. Granulation is more like a healing tissue, right? So it is walled off this amylase rich fluid. Okay, this granulation tissue is helping you wall it off. Okay, so basically this cyst, when are you calling it as a pseudocyst? Once it develops, immediately they are not calling it as a pseudocyst. They are calling it initially they are calling it as a fluid collection. First, what are they calling it as? Fluid collection. For the first 4 weeks they are calling it as a fluid collection. After 4 weeks they are calling it as an acute pseudocyst. The cyst word is coming only after 4 weeks. So usually acute conditions means they will be like sudden. As soon as they come you will call them acute. But this is one case where acute word is used 4 weeks after it has come. Okay. So this is introduction to the pseudocyst of pancreas. Now let us understand where is this lesser sac. Lesser sac it is in, they said, right? So let us find out where the lesser sac is. See, in blue here in this diagram they have shown the lesser sac. This entire thing is lesser sac. Then where is the pancreas? Pancreas is somewhere here. Pancreas will use yellow. What say? See here, this is pancreas somewhere here. Okay, this is pancreas. Are you able to see? We'll use some other color, purple. See, this is somewhere pancreas. Okay, so the pseudocyst of pancreas will be where? In the lesser sac. Okay, in this diagram here, same thing, they have shown lesser sac in a different color, and pancreas they have shown in yellow. Sincerely they have used yellow for the pancreas. Okay, so this is pseudocyst of pancreas. Now why does this pseudocyst of pancreas happen? What is the etiology? That means what is the cause of the pseudocyst of pancreas? The cause is that there is acute pancreatitis. So one of the complications of acute pancreatitis is pseudocyst. What is acute pancreatitis? Pancreatitis means inflammation of the pancreas. Acute pancreatitis means sudden inflammation of the pancreas. Why will that happen? That can happen because of infection, alcohol, gallstones also very important cause of pancreatitis, right? Gallstones. Then post some ERCP procedure, right? Then there are a lot of other causes like renal failure, hereditary, then what else? Metabolic drugs, some drugs like thiazides, diuretics, all that can cause pancreatitis. What will happen in that case? That in pancreas obviously will increase in size, you can say inflammation. It will start secreting enzymes basically, and these enzymes will get activated within the pancreas. So that is the problem, right? The enzymes will get activated within the pancreas and they'll start destroying the pancreas. Those enzymes are digestive enzymes. They are not supposed to get activated within the pancreas. They're supposed to come to the duodenum, and there in the intestine they are supposed to get activated. But these enzymes which the pancreas released now will accumulate here, and they will get activated here, and then they will start causing problem for the pancreas itself. So that is acute pancreatitis. So usually what will happen after an attack of this acute pancreatitis, that is usually appears after 4 weeks as an upper abdominal swelling. What is this? Then so it will appear, this pseudocyst of pancreas will appear as an abdominal swelling, they are saying. Okay. Then blunt injury of abdomen caused by ductal disruption. So basically injury also can lead to pseudocyst of pancreas, wherein the pancreatic duct in the region of the body crushed against the vertebral body results in pseudocyst. Okay, so the pancreatic duct in the region is getting crushed. Okay, then some causes of chronic pancreatitis may be associated with pseudocyst. So it's possible not just acute pancreatitis, even chronic pancreatitis can lead to pseudocyst. Okay, so what is pseudocyst? If they ask you, it's actually a complication of acute pancreatitis, you can say. Okay, then what are the clinical features of this condition? Pseudocyst clinical features. Now how do you think the features will be? Let us assume there's a cyst sitting here, so you can easily say there's a tensely cystic mass in the epigastrium. Epigastrium means just above your umbilicus. No, there you will have some cystic mass. Okay, tense it will be. Umbilical region, yeah, this is, it can be in the epigastrium, umbilical region, or in the left hypochondrium. So where and all? Epigastric, there can be mass, left hypochondrium, umbilical. These three places probably you can feel the cyst. Okay, so that kind of makes sense. Okay, then this cystic mass feels firm on palpation. It feels firm on palpation. You can see this, firm on palpation. Cystic mass, no, so we'll use some cystic mass color only. Firm on palpation, mass in epigastrium, cystic mass in epigastrium. Then what else? Cystic mass in epigastrium, firm. Okay, let's move on. Classically, upper border of the mass is not felt. You will not feel the upper border of the mass. Can you feel the upper border of the mass? They didn't explain why. Is it like behind something? It does not move with respiration because it's a retroperitoneal. It does not move with respiration. All this you have to write, very important points, because you don't always have to go and get an ultrasound or some x-ray or some radiology. You should be able to tell, see, it is not moving with respiration, it's retroperitoneal. Very good. It has transverse mobility. It is moving. Transverse means horizontally it is moving. It does not fall forward. Why? Because it is retroperitoneal. Percussion, it will give resonant note because stomach or intestine is anterior to it. That's what it means. So you'll percuss, you can feel the mass, but if percuss, you will getting resonant note. Why? Because where is the air? Air is in the stomach or in the intestine. But this actually cystic, so it should have fluid. So it should not give you resonant, it should give dull. But why is it coming resonant? Because the stomach or the intestine is anterior to it. Transmitted pulsations from aorta can be felt. Why? Because it is cystic mass. So you can, pulsations from the aorta can be felt on this mass. This is very interesting, right? So from the aorta, that means that has the blood, right? So you can feel the pulsations. Wow. If a Ryle's tube is passed, it can be felt over the swelling. So this is kind of interesting. You'll pass a Ryle's tube. That means into the stomach you're passing something. It can be felt over the swelling. It is called as Baid sign. This is really interesting. Okay. Let's look at this a little more. See, the stomach is there and behind that the cyst is there, let us say. Okay, so inside the stomach, when you're putting this Ryle's tube, it will go over this cyst, isn't it? So that is called as a Baid sign. You will feel the Ryle's tube over the swelling. Depending on the tension within the cyst, it can be tender or non-tender. So you think if there is more tension inside it, it will be tender, right? What do you say? So these are the clinical features of pseudocyst of pancreas. Let's move on now to the location of pseudocyst. So where do you think this can be? Pseudocyst. Look at this CT and tell where you think it is. Here's a pseudocyst. Looks like the stomach is in front. Something is at the back. Okay, so where will it be? Between the stomach and transverse colon, between the stomach and liver, behind the transverse, behind or below the transverse colon. Transverse means what? That large intestine, right? So if transverse colon is somewhere here, this is transverse colon, we can see. So the pseudocyst can be between the stomach and transverse colon. Then what else are the options they give us? Between the stomach and liver, below the transverse colon, or behind the transverse colon. Okay, fine. Now let us go to the classification of pseudocyst. This DeGiDio. Okay, we'll remove this quote. Anyways, it is pronounced as DeGiDio, right? DeGiDio classification of pseudocyst. DeGiDio. So this type 1, type 2, type 3. So there's how many types of pseudocyst? Type 1, type 2, type 3. Okay. So type 1 is acute post-necrotic pseudocyst that occurs after an episode of acute pancreatitis. After an acute pancreatitis, it is associated with normal duct anatomy and rarely communicates with pancreatic duct. Duct and all is normal. Okay, this is type 1. Type 2. This occurs after acute on chronic pancreatitis. This is acute on chronic pancreatitis. So what will happen? And have a diseased but not strictured diseased pancreatic duct will be there. Diseased pancreatic duct but not strictured, and there is after communication between the duct and the pseudocyst. There is after communication means what? There is communication. Okay, we will see that there is some communication between the duct and the pseudocyst. The pancreatic duct is diseased, remember. Now type 3, it has to get even worse, isn't it? This is also called as retention cyst. Retention cyst is the only thing that has a name. Okay, type 3, they named only the third thing, they didn't name the other two. Occur in chronic pancreatitis. Again this is chronic only. What is this spelling? Is it wrong? Uniformly, okay, uniformly associated with duct stricture. Here there is duct stricture, and communication there between the duct and the pseudocyst. Okay, there is communication and there is duct stricture. Duct is affected, pancreatic duct has some problem, it communicates. Okay, so what are the three types of pseudocyst of pancreas? Type 1, type 2, type 3. Type 1 means still things are good after acute pancreatitis, and the ducts are good and nobody has any communication with each other, they all are living their own lives. Then 2 comes, duct is having some disease, and this is after acute on chronic pancreatitis, and this one there can be some after communication is the word they have used. Then coming to 3, the third one, here the duct is having problem, there is communication between the duct and the pseudocyst. Okay, and this is after chronic pancreatitis. Okay, there is communication between the duct and the cyst. Okay, so these are the 3 types of DeGiDio classification of pseudocyst. Okay, now let's go to the investigations of pseudocyst of pancreas. Let's do some investigations. What will you do? Anybody will say nowadays, no, ultrasound CT. Anybody will say, you can detect the size, location of the cyst, thickness of the wall. You can confirm that there is no neoplasm, right? Just before doing the surgery, any surgery you are intervening, you can do an ultrasound, you can rule out neoplasm. Then you can do a barium meal stomach. You will give barium meal to that guy, and then you will see that the stomach is anterior, right? This anybody will say stomach is in front, and you can see that there is some increased vertebrogastral interval. Okay, this is not done nowadays anyways, so no need to learn. Looks like ultrasound CT you write off. Okay, but if you do a barium meal, you will see that the stomach is pushed anteriorly. Okay, this is not done nowadays because you have better techniques. Stomach is pushed anteriorly. Okay, ERCP may demonstrate communication of the cyst with the duct if there is a communication, right? ERCP. So what is ERCP? Retrograde cholangiopancreatography, isn't it? Let me check. This is something we had studied last time. You remember all this we have covered in that acute pancreatitis and all that. Okay. This may demonstrate communication. Okay. We don't like communication. It becomes type 3, isn't it? What is that? DeGiDio. Okay. Now let's move on, guys. Okay. They have shown some image here. Let's look at this. There is a pseudocyst and there is one more. So wow, 3. So this is a large pseudocyst with multiple pockets. Okay. In this they are telling some treatment. We'll come to that later. So basically you looked at the investigations. Now we are looking at the treatment. Pseudocyst of pancreas. Let's look at the treatment. What will you do? Think about it. As a doctor, what will you do? As a normal person, what do you think you should do? You should wait for it to resolve spontaneously. Okay, very good. Then ultrasound, you will observe the pseudocyst. Okay, that you can do. Then you can do some surgery. What will you do? I'm sure you didn't guess this. I thought I will just drain it out, but they're doing some CystoGastrotomy. They're connecting this cyst to the stomach. CystoGastrotomy. Then what else they're talking? Distal pancreatectomy. Okay. So again they're trying to remove the tail of the pancreas and the cyst. So part of pancreas are gone. Okay, then CystoJejunostomy. Look at this image here. If you can understand, they are connecting the cyst to the jejunum and some stomy. We'll have to look at all this, guys. Let us look at the treatment, and then what is this? This is the other treatment. Endoscopic drainage. Oh yeah, this is the first thing that we guessed, right? You just drain it. So easy, less invasive, ideal. Then why didn't they write this first? However, chances of introducing infection are present. Okay. Look at the flow chart for the management of pseudocyst. Pseudocyst can be asymptomatic, then you just observe it. Okay, we'll observe it, no problem. Then symptomatic if it is. What are the symptoms? These people will have pain, epigastric, hypochondriac, left hypochondriac, umbilical, they can have pain, right? Mass. Otherwise, they don't have any other main issue, right? Yeah, that is the symptoms that the textbook says. Now, look at this symptomatic. If it is symptomatic, then what will you do? ERP. What is ERP? ERP, MRP sounds like some price, right? Maximum retail price. But what is ERP? Endoscopic retrograde pancreatography. Then what is MRP? MRP is MRI. Instead of I, they are putting P here. Magnetic resonance pancreatography. Okay. So this is magnetic resonance pancreatography. So you're just going to go and see what is there inside it. Okay. Then what will you do? You will check inside what is there. Is there a communication? Is there a stricture? Is there a normal duct? Why did they put normal on this side? They should put normal on this side according to me. Normal. Okay, if it is normal duct is there, then you will do just some drainage. Okay, we love this percutaneous drainage. Now what if there is communication or stricture? Both of these are type 3, remember? See, communication, duct stricture and a communication. These two are actually type 3. They don't like this. So what do you think they should do here? So if there's communication, they are putting some stent. Stricture, if there is stricture, again they are talking about drainage only. But it is internal drainage, endoscopic internal drainage. See, you are going inside and trying to drain it, okay? And then they are doing some surgical internal drainage plus resection. So you will drain it surgically internally and drain it. And resect it. Resect it means remove it, right? Plus or minus they have put. So is this clear, guys? How will you manage a pseudocyst? Okay. So if there is a communication or a stricture, etc., internally they are, if there is a stricture internally, they are draining it, etc. If there is a communication, some stent they are talking about. Okay. Then in this flow chart, nowhere they are showing. Okay, there's one more portion here, infected. Infected means you will again do drainage. Okay, from the skin only they are talking about. Infected means drainage. Here. But you know what? One thing that is missing in this flowchart is where is that CystoGastrotomy, CystoJejunostomy? Where is all that? Here in this. They didn't tell that. Anyways, we have to look at these surgeries in detail. So now you look, okay. CystoGastrotomy means what they are doing. They are connecting the cyst to the stomach. Okay, everything here is 6. You will do it after 6 weeks because the wall should become fibrous, and then the cyst should be at least 6 centimeter, and the stomy, stoma should be at least 6 centimeter. And for some unknown reason, they don't think that the stomach's content will come to cyst, but cyst contents will go to stomach. It seems. See, they themselves are saying here, for reasons not known, the food does not enter the cyst cavity. This is very strange, right? What do you think, guys? This you can do open method or endoscopic method. Okay, this is CystoGastrotomy. You will do this based on its relationship, right? If it is close to the stomach, etc., you should think about the relationship. Okay. Then here they are showing you the cyst which is compressing the stomach. Then they have opened the cyst and they have opened it into the stomach. Okay. The stoma should be 6 centimeter. This is the anterior gastric wall and this is the stomach. Okay. And here they are showing some surgery images if you want to look at. CystoGastrotomy. Pancreatectomy, okay, that's fine. Now coming to CystoJejunostomy, here what you're doing, you're suturing jejunal loop to the cyst, okay. You're suturing what? The jejunal loop to the cyst, in the most dependent area. See, look at this. Does it make any sense at all? So you're creating a passage from the cyst to jejunum, is it? See, what you must understand here is after duodenum comes the jejunum. The jejunum, see, it's coming here, right? This is the jejunum. Sorry, this is the duodenum. Then you have the jejunum. This jejunum, they've cut here, and then there's some Y loop here. This Y loop is taking the pseudocyst content, right? And then it seems to be proceeding like this. Isn't that what it is? This looks really complex, isn't it? But anyways, what they are telling here in this diagram is that if there is large pseudocyst with multiple pockets, the CystoJejunostomy is ideal treatment. Okay. So this is about CystoJejunostomy. Let us take a recap. We wanted to look at pseudocyst of pancreas in this video. This is basically, it is, where is the cyst? It's in the lesser sac. It contains amylase rich fluid. It is coming from the pancreas. The fluid whichever is accumulating here is coming from the pancreas. Okay. Basically, initially if there is fluid collection, it is called as acute fluid collection. After some weeks, then only you are calling it as pseudocyst. Why is it called as pseudocyst? Because it is not a true cyst. It doesn't have an epithelial lining. Okay, then what is lining it? It has a fibrous granulation tissue. Okay, so that is why it is called as pseudocyst. Okay, and then here you can see the lesser sac. Where exactly the pseudocyst will be? It is in the lesser sac. Okay, they have shown here. Then whenever you aspirate this fluid, actually it will be engine oil colored because it is amylase rich. Okay, it is engine oil appearance. Okay, that you can remember. Pseudocyst of pancreas, why does it happen? Because of acute pancreatitis or even because of chronic pancreatitis, because there is an injury to the pancreatic duct, etc. Then what are the clinical features? These people will have pain, epigastrium pain, and you can feel a mass, a dense cystic mass. You can feel firm mass on palpation in these areas, that is epigastrium, umbilical region and left hypochondrium. Okay, left hypochondrium is here. Okay, so where and all you will feel epigastrium, umbilical region and the left hypochondrium. These three areas the person will have pain. Okay, and then you will have a tense cystic mass here, firm on palpation. Upper border you cannot feel because it is behind the it can be behind, and it does not move with respiration because it's retroperitoneal, and it does not fall forward because it is retroperitoneal. It has transverse mobility. It is going to be when you percuss on it, you will get dull note because actually you will be percussing the stomach and the intestine, which are anterior to this pseudocyst. And the pulsations from the aorta can be felt because the pulsations will get transmitted. Whenever you pass a Ryle's tube into the stomach, it can be felt over the swelling because it is obviously behind the stomach, right? So this is called as Baid sign. Depending on the tension within the cyst, it can be tender or non-tender. So it can be tender, okay, or tender or non-tender based on the swelling. On the tension within the cyst. Okay, focus. Now coming to location, it can be between the stomach and transverse colon, between the stomach and the liver. It can be behind the transverse colon also, or below the transverse colon. Then DeGiDio classification of pseudocyst. You have type 1, type 2, type 3. Type 1 is where the duct is fine, and type 2 is where there is diseased pancreatic duct and there is a after communication between the duct and the pseudocyst. And in type 3 you have it's also called as retention cyst. In this, what will happen, there will be after chronic or in chronic pancreatitis, there will be stricture of the duct and there will be communication between the duct and the pseudocyst. Okay, then what are the investigations? Ultrasound CT is enough. Okay, barium meal stomach not done now. ERCP you can do. Basically you can demonstrate the communication between the cyst and the duct if it is there. Okay, then coming to this is a pseudocyst which is having multiple pockets. Treatment, you can basically just wait for it to resolve, or you can keep it under observation, or you can just endoscopically drain it because it will be less invasive, etc. If it is infected also, you can drain it like this endoscopically, or percutaneous drainage also you can do. Okay, I think we should first put percutaneous drainage here. Percutaneous drainage, and then you can talk about endoscopic drainage. Okay, and then coming to the surgery, there are 2 surgeries here, right? No, 3. CystoGastrotomy. Okay, CystoGastrotomy, where you're connecting the cyst to the stomach, and this you should wait for 6 weeks, right, before doing this, because the wall should be fibrous and thick of the cyst. Then you will make a 6 centimeter stoma, and the cyst also should be 6 centimeter in size. So 6 weeks, 6 centimeter, 6 centimeter, you should remember for CystoGastrotomy. Then this is CystoGastrotomy they are showing here. Then you can also do a distal pancreatectomy, removal of the tail and the cyst. Okay, if the cyst is confined to the tail, remember, otherwise what's the point of removing the tail, right? Then coming to CystoJejunostomy, you will create a jejunal loop first of all, okay, and the cyst is connected to that. Okay, it's not like connecting cyst to the jejunum. There is something else here. There is a jejunal loop. You should not forget this is a jejunal loop. Okay, it's very important, jejunal loop. Okay, and this is what is CystoJejunostomy. Especially if there are multiple pockets like this of the pseudocyst, then you can do CystoJejunostomy. Okay, so here they are saying the flow chart. So basically what are they doing here? If it's asymptomatic, just observe it. Then if it is symptomatic, then you do an ERP, that is endoscopic retrograde pancreatography, or you can do an magnetic resonance pancreatography, and then you will check if it is a normal duct or a stricture or a communication. If it is normal, just you can do a percutaneous drainage. If it is infected, also percutaneous drainage. Now if there is communication or stricture, a little more complicated, you'll have to put a stent, or you can do an internal drainage, and this internal drainage you can do endoscopic, or you can surgically drain it, and they are doing some resection. Possibly this is what they are referring to in CystoGastrotomy, CystoJejunostomy, etc. Okay, so this is all about pseudocyst of pancreas. Hope you understood. Bye bye.